Dr. Borrell is a social epidemiologist with research interests in race, ethnicity, socioeconomic position, and neighborhood effects as social determinants of health. And I'm very grateful for Luisa's willingness to take time out of her schedule and to speak to our faculty and students in the department today in this setting. So thank you so much, Luisa, and I'm going to hand the podium over to you.
Good afternoon, everyone, and thank you, Levi. And that's very true that I had never presented in the department as a whole. And as you mentioned, I'm in social epidemiology, but aside from the interest that you mentioned, I'm very interested in the Hispanic population. It's impersonal for me. So my plan today is to talk a little bit about the Hispanic population in the US, describe the Hispanic paradox and how the diversity of the population fit in with this, and talk about the challenge facing and going ahead with the paradox. So just to start, as of 2020, the census 2020, Hispanic represent the only ethnic group in the US. And the idea behind the term is that include everyone that identify as Mexican, Puerto Rican, Salvadorian, Cuban, Dominican, Guatemalan, or any other Spanish cultural origin. But just to talk a little bit before we got to the Hispanic label, let's walk a little bit through the history. Mexican Americans have been in this country since the 1800s. In fact, half of this country used to belong to Mexico and was taken away by what is called the Cold War in 1846, 1849. So Mexicans were counted at the beginning as an origin, and later in 1850 as a race. That didn't pan out for a long time. Then came Puerto Ricans. The Puerto Rican migration started in 1898 when Puerto Rico became an independent state of the United States. And they were counted for the first time in 1960. That was followed by the Cubans after the Cuban Revolution in 1959-60. In 1970, there was added, in addition to Hispanic and the origin, is a Spanish origin cell identifier to the question in the census. But that mandate came a little late, and it was only added to the census to the long form that goes to 5% of the population in the US. So the count wasn't really capturing the entire population. But in 1977, the Office of Management and Budget actually proposed some standardization for the way that we were collecting race and ethnicity for federal reporting and administrative standards. So with that, there was the mandate to collect information in race and ethnicity through two separate questions. The year 2000, the Latino hyphen to the Hispanic-Latino or Spanish origin cell identifier was added to the census form. And if you recall from 2020, when you completed your census, you have two questions. The first one was about ethnicity, and there you had the choice to report whether you are Hispanic, and if you are Hispanic, you can choose an identifier based on the country of origin or nationality. But regardless of whether you identify as Hispanic or not, you have to answer the race question. And for the first time in 2020, choices were actually given for the white and the Black population, whether they they can identify with particular ancestry or a particular country of origin. That all is going to change, and perhaps in 2030, given that in March of this year, there was a change in the way that the data on race and ethnicity is going to be collected. And instead of two questions, it's going to be a combined question. And among the change is that the sum of the race is going to disappear, and a category for Middle Eastern or Northern African was added, or MENA. And the whole idea behind this new proposal is to push people to identify with a particular category. In the 2020, 50 million people identify with some other race category. And out of those, 95% were Hispanic. So with this question, the aim is to reduce the missing and the number of people that identify with categories that mean nothing, especially in the context of what the OMB supposedly collect data on race and ethnicity, which is for purpose of geographic distribution, equal employment opportunity, political representation, budget allocation, and health equity. So that should help with that. So in the context of what ethnicity means, the whole idea behind the concept is that it's going to capture values, norm, and practice, belief, and behavior shared by a particular group of people. In the case of Hispanic, that culture is tied to the language. Language represents the common glue for Hispanic. And the idea behind this is that this culture is going to be distincted and it's going to be passed from generation to generation. And of course, it's going to provide a sense of social identity and belonging to a shared culture that is going to be distinct and that is going to be associated with history and family origin, behavior, belief, you name it. Who are the Hispanic in the US? In 2020, Hispanic represent almost 20% of the population, 62 million. They outgrew the expectation for 2020, and the latest estimate in July 2023 indicate that the number is up to 65.2 million. And the population is expected to grow, assuming that massive deportation don't start soon, is supposed to grow by double, 128 million. But what is unique is that despite the fact that all this charade have been put on and a name and a label, there is different way that Hispanic like to identify themselves. For example, more than half of Hispanic prefer the term Hispanic despite the fact of the history of colonization. About 30% prefer Latino, and now new terminology is emerging. For example, Latinx and Latine. So since 2019 to 2023, approximately 47% say that they have heard the term Latinx, and 4% use the term. And it is a very particular demographic: college student, female, LGBTQ plus, you name it. And approximately 18%, 20% have heard the term Latinx. The difference between those two terms is that with the first one, it is hard to swallow within the Hispanic population, given that X doesn't have a pronunciation in the Spanish language. But it seems to be very popular in the US. And speaking about that, this term had been around since 2000, but it became very popular after the shooting in the PLoS nightclub in Orlando, Florida in 2016. But in general, the term is supposed to be inclusive with a gender neutral, and the idea is that it's supposed to capture gender and ethnicity identity, but that's very problematic because a large proportion of the Hispanic population don't like to be called that way, and 40% get bothered or offended by the term. So some of the recommendation is that if you are using data that is being collected already, don't use Latinx. Use the term that was used to collect the data. And if you plan to collect primary data, explain to people what is the meaning and the purpose of the term, and provide it as an additional term, not the only term for identification. So the idea behind the Hispanic population is that it's a homogeneous or monolithic group. But in reality is that we are very far away from that. We are in fact very heterogeneous. When it comes with country of origin, in 2020, the population identified with at least 19 countries in Latin America and the Caribbean. If you talk about race, Hispanic can be of any race given the history of colonization. Nativity status, although we think about it as a foreign born and US born, it is more complex than that. We need to account for language, citizenship and legal status, generation, acculturation, etc. Socioeconomic position, there is a lot of variation in socioeconomic position within the Hispanic population, with Cubans and Argentinians being in the high stream of the income and having other groups at the low end, like Mexican and some of the Puerto Ricans. If we think about how Hispanic identify when it comes to country, Mexican American represent the large proportion of the population, 62% of the population, followed by Puerto Ricans and Dominicans as group separate. If you account for region, Central American will be the next group. Identification, as I mentioned before, the sum of the race seem to be the preferred identification, and that may be a rejection to the racial category of the US. So 42.2% of the population identify with the sum of the race category, and the rest, the other two groups that I mostly pick up is white and Black. When it comes to nativity status, the Hispanic population represent 44% of all the US foreign-born population. So you can literally think about encounter one out of three Hispanic being foreign-born. 75% have been in the US for at least 10 years, and 40% is US citizen. More than 2/3, or 70% of the population is English proficient, and this number is much lower for the foreign-born. So there is a lot of variation. You also have first generation people that are foreign-born or immigrants, second generation, someone that is US citizen but have at least one parent that is first generation, third generation, someone that is US citizen with both parents being born in the US. Education. So education and household income has a very interesting distribution in the US. When it comes to the Hispanic population, they tend to be less educated, but have a higher income than African American, which is the minoritized group that is closest to Hispanic. Poverty and health insurance. Despite the fact of the passing of Obamacare, we still have 26 million of people without insurance in this country, and that may change in the near future. So Hispanic are more likely to be uninsured than any other group in the US, and the vast proportion of people without insurance is within the age of 18 to 64, which makes sense because in the two extreme, you have Medicaid and Medicare covering to some extent some of the population. When it comes to poverty, you have 11% of the US population living below poverty. So Hispanic are around 17% of the population living below poverty. So now, what is all of this mean for the Hispanic paradox? The Hispanic paradox is based on the fact that despite the low socioeconomic status and the lower access to healthcare that Hispanic have, they tend to have health outcomes that are either similar or better than non-Hispanic whites. And this has been attributed to a wide range of explanation: culture, social support or familism, selective migration, lifestyle factor that in some cases can be protective, genetic heritage, acculturation, ethnic enclave, data issues, whether it's misclassification or accuracy of the data, all of that. So the paradox was coined in 1986 by Marquides and Correa. And the fact that put this on the map is that they observed this paradox among the Mexican American population in the Southwest throughout the 70s and 80s. And they noticed that the paradox was stronger among foreign-born and recent immigrants. They observed this paradox across a wide range of outcomes, infant and adult mortality, whether it's all-cause mortality, CVD, or cancer-specific, life expectancy, and a wide range of outcomes, diabetes, hypertension, you name it. And just to provide some context to this, infant mortality, for example, an indicator of a country well-being. So if we can see here that from 1983 to 2000, the infant mortality rate for Hispanic is literally indistinct than the one from non-Hispanic whites. Meanwhile, if you notice non-Hispanic Black, which Hispanic share more characteristic with, are almost twice the rate of infant mortality than Hispanic. The same can be seen with life expectancy. Even after COVID, when Hispanic lost 4 years between 2019 and 2020, still Hispanic has an advantage over non-Hispanic whites. But we can see a little bit of that in New York City, where we have a more diverse population. If we use the aggregate Hispanic, we can see that their outcome for low birth weight and infant mortality are in between African American and non-Hispanic white, but they are much better than non-Hispanic Black. However, if we disaggregate the population across the different subgroup, we can see that the paradox doesn't fit with all of the group. Especially Puerto Rican tend to have outcome very similar to non-Hispanic Black. So looking back, the paradox was observed among Mexican American in the Southwest in 1980s, 70s. At that point, the overall population was 14 million. But now the population has increased to 65 million. And with that increase, there have been a lot of increase in diversity. The other thing that is important to know here, before 2000, the growth of the population was due to immigration. After 2000, it had been all about fertility and birthing. So that's going to have implication going forward. So as we look forward, we had to account for the cultural diversity of the population. There have been an increase in the recent year of immigrants from Honduras, Dominican Republic, Guatemala, and Venezuela. We can see in New York City, for example, that we have approximately 275,000 immigrants from Venezuela. And the difference between the immigrants that are coming now and the early cohort is that they come from across the lifespan when it comes to age, and with that bring some diversity and health as well. So you get healthy and you get unhealthy people. The other issue that we are seeing in the recent immigrant is that there is a high proportion of indigenous people that don't even speak Spanish. And this is coming from Mexico, Guatemala, Honduras, and even Venezuela. Second, acculturation is happening for a big proportion of the population, and with that, there are being lost some of the traditional practices that were healthy and keep the paradox alive. We are also losing social support, the respect for the elderly, and familism. Those are issues that affect the paradox. The distribution of the Hispanic population is in specific places, and we have seen over the past 10 years an increase in xenophobia or an anti-immigrant sentiments, and that's is going to get worse going forward. We know that in sanctuary cities, people do much better in the context of mental health, the use of emergency department, and asthma for the kids. So this is definitely going to have a tremendous impact on the Hispanic paradox. The other issue that have been always an elephant in the room have been issues around the Salmon bias, or the fact that people come here, work, and when they get sick, they go home and die. This hypothesis has been debunked over the years. First, because Cuban, which is the population that lives longer and that is more healthy, they cannot go back. Puerto Rican, no matter where they die, they are going to be counted. And based on some data from Mexico and the US, it has been also noticed that if there is any misclassification or any inaccuracy in the data, it's minimal, and it cannot contribute to the advantage that we see in mortality and in life expectancy. Racial identification is a big issue. We have seen also an increase on discrimination against the Hispanic population. And it is interesting because the discrimination come from different angles. It comes from the non-Hispanic population, regardless of race, Black or white, but it also comes from the Hispanic white population for the Hispanic with a darker skin color. And over 50% of the Hispanic that are dark skinned say that they feel discriminated on a daily basis and that their color is precluding them from getting ahead in life in the US. So where do we go from here? First, the population is expected to increase, and with that increase, it's going to be also an increase in diversity of the population. Immigration patterns. We don't know what is going to happen with immigration, especially with the new president. But if immigration were to continue, we know and we notice that the recent immigrants are very different than their early cohort, and the healthy effect or healthy selection that used to be before is not happening with the recent immigrants that are mostly refugees and asylum seekers. Acculturation, we know that with acculturation, it comes an increase in unhealthy risk behavior, loss of social support and familism, and those are issues that has implication for health. As I mentioned before, the political climate is not going to be any easy, so xenophobia is supposed to increase, so it's expected to increase. And with that, we are lucky that we live in a blue state, and it's considered, the city is considered sanctuary city, but we will see a lot of issue with undocumented, and the evidence suggests that anyone that has seen a deportation for an undocumented relative friend, it is an event of PTSD. Finally, changes in identity is going to be a problem because as the umbrella started to dilute with all this identity, that's going to create issue for identification and for the determination of the health status of the population. So just to close, the Hispanic population is far from homogeneous, and within the heterogeneity of the population, we must account for country of origin, nativity status, and all these factors that sort of influence health. These are important because if we don't account for this, we don't get a full picture of the population. And we need more granular data if we are serious about health inequity. And this is not unique to the Hispanic population. I think right now, every single group that we collect data for has a lot of heterogeneity when it comes to health. So I think that collecting data as granular as we can, it is a must if we are serious about health inequities. And with that, I thank you, and I take any question now or at the end, you tell me.
Thank you, Luisa. We can take a question or two now if anyone would like. We'll also have a chance at the end of both of the presentations to have a couple questions before our small group discussion, if we can figure out how to do those. Dennis.
Yeah, I'll go. Thanks, Luisa. That was awesome. I've heard you speak about some of this before, and it's really great to to hear from you again about this issue, and also at this time.
And it wasn't planned. It wasn't planned. I didn't even put it together.
Yeah, I think it's going to be really, I mean, it's already a very important topic in epidemiology and public health, and now it's just going to be even more elevated, I think. My question is, when you're comparing the health of different populations, like say in life expectancy or infant mortality, a lot you mentioned a very large proportion of Hispanic people in this country are born outside the US. And I think you mentioned this. I mean, and my sense is that many people come here because of the opportunities for work, and to be able to send money back home to areas where they maybe didn't have the same work opportunities to help their families and so forth. And so that made me think of this as occupational phenomenon called the healthy worker effect. And I wondered if that's ever come up as like a potential explanation for some of the differences.
Sure. At the beginning, that used to be the big chunk of the immigration. It used to be young men, healthy, that would come to work. And as you say, send money back. But over the year, the immigration had changed. And more recently, even more with the asylum seeker and refugee. So this whole dynamic is changing. And it will be interesting to see what happened in the next 5 to 7 years. Because even up to 2022, which is the data that we have, we still see the difference and the advantage of the Hispanic population. But once we start to put all these people that came in the pool, things may change, because it's not only the unhealthy, but it's also that this is happening across the age span. So it is a lot to change, and those are challenge for the paradox. So it may be something that disappear or only can be observed among the Mexican population and not in other immigrants.
I feel like I've heard of another. I feel like I've heard of another. I don't know if call it a paradox, but of how the first generation immigrants can have health outcomes different than subsequent generations of immigrants, which become more similar to other U.S. born immigrants. And I wonder if that could be related to healthy worker bias.
Absolutely. We acculturation. We see that some of the health advantage disappear as people live longer in the US. And we also see that people that do the best are the biculture, the people that integrate in the society, but at the same time maintain their culture through either home, family, friends. Those are the people that do the best.
All right. Well, thank you, Luisa. We will have some time for discussion at the end as well, for everyone who sticks around. So thank you, Luisa. I'm going to bring on our other guest now, who I believe is here. Lauren Buscarino, are you here?
Yeah, I'm here. Can you hear me okay?
Yes. Yes.
Okay, great. And then my camera's
Hello.
on. Hey.
Great. So our second speaker is a recent graduate of our MPH in Epidemiology and Biostatistics, and one of our star students. She was a recipient of the Dean's Merit Award for Excellence, and has research interests on perinatal HIV survivors, diagnosis, disclosure experience. Lauren is about to be, or I don't know if you already have started a research analyst position with Bronx Health Collective at Montefiore Medical Center, and presented her research at the IAPAC conference in October, which was how I knew that the department should invite her to speak at our forum. So thank you so much for coming here to speak to our faculty and other students who have come today. And I will pass the microphone over to you, Lauren.
Great. Thank you for that wonderful introduction. It is a pleasure to be here. So thank you so much for having me. And with that being said, I will go ahead and share my PowerPoint. Okay, Linda. Okay. Does everybody see my screen? Yes. Okay, great. Okay, well, again, my name is Lauren. I am a CUNY SPH alumni. It's a pleasure to be here, and I am currently a research analyst with Bronx Health Collective at Montefiore Medical Center. So today I'll be presenting my master's essay research, which was done alongside Dr. Zachary Sean, Dr. Elizabeth Cabrera, and Dr. Ivy Turnbull. And we'll be talking about the impact of the initial diagnosis disclosure experience on the long-term mental health outcomes of the longest living survivors of perinatal HIV. So in 2019, there were over 12,000 individuals in the United States living with perinatal HIV, which is HIV that is transmitted from a mother to her child during pregnancy, breastfeeding, or delivery. Diagnosis disclosure is the critical point, and sometimes this occurs over multiple time points when an individual with perinatal HIV learns that they have HIV. The context of this experience, particularly who tells the child of their status and at what age they learn about their status, can either negatively or positively impact these individuals. So currently, the World Health Organization recommends that this disclosure occurs between the ages of 6 and 12 to generate the best health outcomes for children. However, we find that most often this occurs later in time. Problematically, delayed disclosure has been associated with poor mental health outcomes in youth. So previous studies have shown us that individuals prefer that disclosure occurs from a provider with a parent or parents alone. However, there is a lack of concrete guidance on whose role it is to disclose to a child. And as a result, this could feed into delayed disclosure and why we're seeing these disclosure occur later in time. So previous research also shows that survivors' negative feelings about their disclosure experience can re-emerge later in life. Now, perinatal HIV survivors are living into adulthood and emerging into adulthood beyond the age of 25 years old and really defying what was previously thought to be impossible without antiretroviral therapy. So, perinatal HIV adults may continue to be re-traumatized by their experience if these feelings continue to re-emerge later in life. However, this question is difficult to answer because research with this group is very scarce. It's very limited. And specifically looking at the impact of their age at diagnosis disclosure and the identity of their disclosure is understudied, specifically the impact on their mental health. So we wanted to know, how would survivors' current mental health status differ if they had been disclosed to by a parent or guardian at a young age, which is known to be more favorable, compared to a healthcare provider at an older age? So participants from this study came from the Beating the Odds Living with HIV from Infancy to Adulthood study, or otherwise known as the BTO study, specifically from the quantitative survey. So the BTO study is currently examining and trying to understand the lived experiences of perinatal survivors, perinatal HIV survivors, specifically adults, pertaining to their quality of life, their medication adherence, as well as their mental health. Participants in this study were 25 years or older, resided in the United States, and had acquired HIV from mother-to-child transmission. The BTO study investigators recruited their sample through a snowball sampling design in which they contacted key community stakeholders who were able to distribute the surveys, and they also were able to recruit through social media by disseminating the survey to eligible participants through social media. So we used an adjusted logistic regression model to estimate the standardized contrast between poor mental health prevalence given disclosure at age 6 by a parent or guardian versus disclosure at age 18 by a healthcare provider. Under the assumptions of consistency, positivity, exchangeability, and correct model specification, this would be known as the average treatment effect. So why are we using the average treatment effect? Well, we were interested in looking at how survivors' mental health status would differ, their current mental health status, if they had experienced the alternate disclosure experience or the counterfactual. We were also interested in estimating the population level effect outside of the constraints of our sample. However, because we can't estimate the counterfactual in real life, we're looking at the average treatment effect. So this predicts all survivors' mental health outcome for each disclosure experience arm using a statistical model, subtracting the means to get the mean difference, and then interpreting this as the risk difference or the difference in risk in experiencing a poor mental health status currently between disclosure experience arms. So just to show you where we got our data from, we had 2 exposures and 1 outcome for this study. Our first exposure were participants' age at diagnosis disclosure, which was measured by the survey question, how old were you when you found out that you were HIV positive? This was a write-in response and a numerical variable. The second exposure was participants' disclosure identity, and this was measured by the question, who first told you that you had HIV? And there was a number of response choices, but we did condense these categories to parent or guardian, healthcare provider, and then other for the purpose of this analysis. And then finally, our outcome measure was current mental health status, which was measured by the question, overall, how do you feel? And we also condensed those categories to either negative or positive for the purpose of this analysis. So overall, we had a total of 70 participants in our final sample. Over half of our participants identified as female, and over half were told by a parent or guardian of their serostatus. Over 3/4 of participants identified as Black or of African American descent, and over 3/4 were also between the ages of 25 and 30 years old. Notably, 2/3 of our cohort had experienced a poor mental health status, or they had reported on 3 out of 6 of those response choices, which was indicative of poor mental health. Importantly, we noticed that the mean age at disclosure was 12 years old, and we found that the age at disclosure significantly differed by disclosure identity group, as those who were disclosed to by a parent or guardian were on average younger than those disclosed to by a healthcare provider. And if I recall, the mean age of disclosure for those told by a parent or guardian was about 9 years old. So here we have a graph to show our participants' age at diagnosis disclosure, which is on the y-axis, by the identity of their disclosure, which is on the x-axis. You can notice the thick black dashed line in the middle, which is representative of the mean age at diagnosis disclosure for the cohort. And we can also see how those told by a parent or guardian tended to be younger compared to those told by a healthcare provider. Also, we notice there does not seem to be a pattern in the distribution of long-term mental health status by either variable. So our main finding, our average treatment effect, we found to be was negative 0.10, and the confidence interval was between negative 0.34 and 0.13. So this means that if we interpret this, the overall risk of experiencing a negative long-term mental health status would be 10% lower or reduced by 10% if all survivors had been disclosed to by a parent or guardian at the age of 6 versus if all survivors had been disclosed to by a healthcare provider at the age of 18. However, it's extremely important to note that the confidence interval for this estimate is too wide to be informative, as it spans 0. Thus, disclosure by a parent or guardian at the age of 6 could be detrimental to children or survivors' mental health outcomes. Just recapping our main findings, well, we found that age at diagnosis disclosure differed by disclosure identity group, and that survivors' risk of a poor mental health status later in life could be reduced by approximately 10% if they're disclosed to by a parent or guardian at the age of 6, although, as mentioned, the confidence interval is much too wide to be informative. So when we're looking at previous research and other studies, to compare our results, we find that previous studies found that the average age of disclosure was 12 years old, which is similar to ours. And previous studies also found that disclosure in general, so just informing a child of their serostatus, does not worsen their mental health. And that was a great finding because there was a lot of fear that disclosure was going to worsen their mental health. However, a majority of these previous studies pertain to youth, so they're much younger than the sample. And they also do not measure the impact of disclosure identity, which our study did. The most similar study we found to ours found that young adult survivors had felt neutral or reported a good quality of life regardless of their disclosure experience. However, this study was qualitative and they had systematically different participants, in that their participants reported extremely high levels of social support at the time of disclosure, and also had experienced, some had experienced loss or abandonment by a parent or guardian as well. But to my knowledge, this is the first study that examines the impact of the age of diagnosis disclosure and the disclosure identity on their long-term mental health, specifically adult survivors, in which, research with adult survivors is currently very scarce. So going forward, we propose the following recommendations. 1, we propose to increase the sample size and the representativeness of our cohort in order to boost our statistical power as well as our accuracy. So we were only able to collect data from participants from 15 states. So in order to increase our reach, we propose, possibly reaching out to the Ryan White program at state health departments to possibly help us with recruitment, and then that could help our representativeness. Second, we propose to control for social support and loss or abandonment by parents as their possible confounders. So social support could be indicative of disclosure by parents, and also it's associated with better mental health outcomes. And then similarly, loss of or abandonment by parents, it could make it less likely that a child will learn from their parents if they've lost them or if they're not in their life anymore. And then also it could impart youth with a specific, a unique long-term mental health status, as they may be faced with a unique kind of grief and coping mechanisms as a result of the loss or abandonment by their parents. And then last but not least, a potential study design that we could consider going forward would be something like a cohort study where we can use frequent follow-up periods, specifically to reduce recall bias, because for some participants, it's been a very long time from the time they learned of their disclosure and, they were disclosed to, and present day. So there could be recall bias. So to conclude, disclosure by parents or guardians at a young age could protect survivors' mental health later in life. However, likely due to the limitations of our study, the confidence interval was too wide to be informative. Either way, the point estimate invites the opportunity for future research, and the research question itself invites us to think deeper about having this conversation about how diagnosis disclosure can impact youth mental health and as well as their mental health later in life. Ultimately, we need to diminish the ambiguity around diagnosis disclosure in order to, 1, protect our youth, specifically from the harsh legal consequences that are often imposed on them for their failure to disclose to either sex or needle sharing partners, when it was our failure to disclose to youth in a timely manner because we are lacking those concrete guidelines. And then second, to foster their positive development across the lifespan and to increase the breadth of research around perinatal HIV and specifically perinatal HIV adults. So thank you. And I'd just like to thank a few people, Dr. Zachary Sean, who is my faculty advisor, Dr. Elizabeth Cabrera, who is my mentor and BTO study co-investigator, Dr. Ivy Turnbull, also the principal investigator on the study, and then Barbara Zelag and Marilyn Merida, who are team members, and then the CUNY Graduate School of Public Health and Health Policy. So thank you very much.
Thank you so much, Lauren. And we have time for a couple of questions now. We can take questions for either speaker now, if anyone has them. I had one first question for Lauren, which was just how prevalent is perinatal HIV in the United States?
So it's a very, very small percentage of total HIV cases, less than 1%. And I think that's part of the reason why there's not much conversation about, pertaining to this cohort, and specifically looking at how to improve their retention and care, their adherence to medications. Mm-hmm. So it's a very, very small group. So we're really trying to increase their representation in research.
Dennis.
Hi, Lauren. Great presentation. And really important topic. Yeah, I mean, related to Levi's question, because we have had so much success with treatment of people living with HIV, including pregnant women in the US, there's very little perinatal acquired HIV today. And also C-sections are common here as a strategy to prevent and in some cases avoiding breastfeeding. But if you look in places around sub-Saharan Africa, there's still tons of perinatally acquired HIV happening because of major gaps in all these areas. And I just wanted to highlight for you, and disclosure is a huge issue. And compounded by the fact that many of the children who have perinatally acquired HIV are orphaned because their parents die also of HIV. This is, of course, getting better when treatment got rolled out, but we have a cohort study called the IDEA Network where we enrolled a bunch of people who we call it the Adolescent and Young Adult Network, young network of it's a YANI. I forget what it stands for, but I want to say more than 1,000 adolescents and young adults were enrolled, and more than 60% of them, I think, were perinatally acquired HIV. And I think we do ask about disclosure in that cohort, and I'm not sure that an analysis like this has been done. Certainly, there's people describing what the disclosure experience was, but to be able to do a study, especially when people are at a much younger age, recalling things in a more accurate way. If you're interested, I know we've corresponded about this work. If you're interested, please reach out and I'll be happy to connect you. But I think that the relevance of these kinds of questions in the sub-Saharan African region is even higher.
Absolutely. And thank you so much for those thoughts. And it's so reassuring to know that somewhere, that data is being collected. It's really a pivotal time at that age to start collecting that information. And, mental health status changes across the lifespan, but to be able to reduce recall a little bit to get it earlier on is really ideal. And I mean, the need abroad is overwhelming, despite the improvements that we've made, and there's still so much to be done. And fortunately, you know, our sample size was actually greatly reduced because we had a lot of people who were taking the survey from abroad, and actually that was a majority of our responses were from abroad. So we know there's still so much need out there that we need to really dive into. But I would love to connect on that. That would be really great. It sounds very, very interesting. So thank you.
There's also a comment from Dennis in the chat, in case you haven't seen it, about the need to connect.
Oh, yeah. Right. If you're not already connected with the Einstein Rockefeller CUNY Center for AIDS Research, or CFAR, it's another thing that you might want to do, and I can help with, because I heard from your introduction that you're at Einstein now and used to be at CUNY. So
yeah, that would be great. Yeah, there. I looked at a lot of the literature around that body, and a lot of really great work there. So I'd love to connect there as well. It'd be great.
Lauren, we have a
you.
question from another of our faculty members too, Carmen Williams, about whether you have any thoughts on differences in the stigma of perinatal versus acquired in other ways.
That's a really great question. I think where some of the difference lies is there are these feelings that people who had acquired HIV from perinatal transmission have towards their moms. And there is a certain stigma in familial HIV, and you know, it's not just a family member that has it, but it's also yourself. And there's also a lot of resentment towards parents. So there's really like this added layer of stigma that occurs in like the interpersonal sphere among the family unit that doesn't necessarily occur when it's acquired in other ways, such as through needle sharing or through sexual partners and such like that. But I think what's similar between the two is just youth who are growing up and having HIV and having to navigate their very first interactions with people, and specifically in relationships. And a big topic in research is also disclosure in relationships, and how do you tell your partner about your status. And so there are just many layers of stigma felt by people who are perinatal acquired, but then also people who acquire HIV in other ways.
Thank you. All right. If there aren't any more questions now, I first want to just say that our next forum will be on a Thursday, December 5th at the same time, 3:30 p.m. That one is going to be with Professor Deborah Balk from Baruch College, and our student who is her advisee, Jenna Tapaldo, also a recent graduate. That's going to be an interesting one because it's work that they worked on together, and they're both going to present different aspects of it. It's titled Aging and Health in a Changing Climate, from Framework to Empirical Analysis. So that's in a month on December 5th. And now I hope some of you will stick around and have some discussion in small rooms. We'll create some breakout rooms and put Luisa and Lauren in different rooms for you to go meet with, and maybe we'll create a third room as well for anything else. And I encourage discussion on broader topics as well. This should be just informal time. It won't be recorded. It's a chance to talk about whatever is on your mind, and for us to get to know each other. So thank you everyone for coming, and I look forward to talking